Hi, everyone. Welcome to the All Things Amyloid podcast, where we feature patients, caregivers, and clinicians who discuss amyloidosis, a rare and incurable disease. Amyloidosis occurs when the body builds up abnormal amounts of misfolded amyloid protein, which can lead to serious and life threatening outcomes. I'm your host, Mackenzie, an amyloidosis patient and founder of Mackenzie's Mission. Our goal for this podcast is to raise awareness and share firsthand what it's like to live with this disease, to care for those affected by it, and to treat it. We hope this leads to earlier diagnosis and start of treatment, which will improve patient lives. As we launch our podcast on all things amyloid, we thought it important to provide a brief clinical overview of the disease. In today's episode, we'll hear from Dr. Sarah Lee, Assistant Professor, Division of Hematology at the City of Hope. She'll provide a brief yet comprehensive clinical overview of amyloidosis. Dr. Lee will discuss what is amyloidosis, most common types, the wide range of symptom presentations, and which organs are typically involved, focusing predominantly on AL, or light chain amyloidosis, and TTR, or transthyretin amyloidosis. She will then go through a diagnostic workup to arrive at a diagnosis, stressing the importance of typing once the presence of amyloid has been confirmed. In conclusion, Dr. Lee will describe treatments available and how they impact patient quality of life and prognosis.
Hello, my name is Sarah Lee. I'm a hematologist, oncologist, and assistant professor at City of Hope, where I specialize in seeing patients with plasma cell disorders with a special interest in amyloidosis. So what is amyloidosis? Simply put, it's a protein misfolding disorder. Normal soluble proteins aggregate as extracellular insoluble amyloid fibrils, which then can deposit into any organ system, causing functional and structural organ damage. It's a generic term for this abnormal protein deposition, so it's important to recognize that there's over 20 specific types of amyloid and at least 42 different known precursor proteins that can actually cause these amyloid fibrils to have the downstream effects of causing localized and/or systemic disease. This table is just a sampling of the different types of amyloid and their precursor proteins, the underlying disorder that it's related to, and the different organs that are commonly involved. We will be focusing on the light chain type and the TTR type, or AL, or the transthyretin type. But I do also want to bring up the AA type, which is commonly seen in conditions of chronic inflammation or even chronic infections. And so something that is certainly commonly seen, again, a rare disorder, but one of the more commonly seen types of amyloid. So how do patients present? Again, amyloid deposits can result in a wide range of clinical manifestations depending on the type, location, and the amount of protein that's deposited. Some of the more classic signs or exam findings or things are like enlarged tongue or macroglossia, periorbital bruising, or thickened waxy skin due to dermal infiltration of amyloid proteins. But more commonly, patients are going to be coming in with these obvious signs, and it requires a high level of suspicion. More often than not, patients are going to come in with vague constitutional symptoms or even symptoms that you might consider just to be common run-of-the-mill things that are just typical and maybe related to a common diagnosis. So, weight loss or fatigue, shortness of breath, new onset edema, maybe some complaints of numbness and tingling in their hands and feet, chronic diarrhea, all things that may not necessarily trigger you to think about this rare condition. But certainly, misdiagnosis can lead to catastrophic outcomes. So things to think about, certainly if you have a patient with new onset unexplained heart failure, but they don't have any history of cardiac disease, no history of a heart attack or different things that you might think about, again, thinking about amyloidosis. A patient who has neuropathy can easily be contributed to diabetes or back, maybe spinal stenosis. But if they don't have a history of these things or they have a history of diabetes that's been well controlled, learn to kind of think outside of just what the common things are and include amyloidosis as part of your differential. Though amyloidosis is rare, it's vitally important to keep it, in your differential because early diagnosis and early initiation of treatment is key to prevent further organ damage, improving overall survival, and certainly improving patient quality of life. So most of you are probably familiar with these buzzwords associated with amyloidosis. So things like Congo red, being Congo red positive on a pathology report, or these characteristic apple green birefringence under polarized light. But these are all tests that just confirm the presence of amyloid deposition. Again, this is a generic term for amyloid. Once you identify that there is a presence of amyloid, it's important to go ahead and get typing done, whether that's by mass spectrometry, electron microscopy, or even immunohistochemistry to really identify what is the type of amyloid, as this will affect prognosis, treatment, and looking for other workup. So the two most common types of amyloidosis are the light chain or AL amyloid, or the transthyretin or the TTR amyloid. And it's important, again, to distinguish between the two, as they are both the pathophysiology is unique and the treatment is unique. So the light chain amyloid is related to a clonal plasma cell disorder, meaning there's an abnormal plasma cell population in the bone marrow causing an overproduction of abnormal immunoglobulin light chains or a monoclonal light chain. And these are either kappa or lambda. The kappa and lambda free light chains are normal components of the antibodies. And so again, one of these is overproduced from these clonal plasma cells. These light chains can misfold, causing the amyloid fibrils, and then these can deposit into any organ system, causing functional damage. The AL amyloidosis is typically associated with other plasma cell disorders like multiple myeloma, can also be seen in other hematologic conditions like certain types of lymphomas, but can also just be a standalone condition and not related to an underlying hematologic malignancy. Transthyretin is actually a transport protein for thyroxine and retinol. It's a precursor protein that's produced by the liver, and it's normally in a tetramer conformation. But what can happen is these tetramers can disband into monomers, and it's these monomers which can then misfold into the amyloid fibrils, which then can deposit into organs and again cause damage. This can occur either spontaneously, as seen in the wild type TTR, or can be related to an inherited gene mutation, which we see in the hereditary type. The wild type TTR is previously known as senile cardiac amyloidosis. And it's because it typically affects older males and presents as a late onset hypertrophic restrictive cardiomyopathy. It's often preceded, could be even years, by carpal tunnel syndrome or even spinal stenosis or both. And as you get older, the normal TTR protein becomes unstable and more prone to misfolding and can cause, again, these amyloid fibrils. The hereditary TTR type is caused by different point mutations in the TTR gene. There's several point mutations that can occur, and these cause the TTR protein to become unstable and again prone to forming amyloid fibrils. It can manifest as cardiomyopathy, but it can also manifest as polyneuropathy or a mixed phenotype, and it depends on the specific mutation that is related to the hereditary form. So recent developments and effective therapies have dramatically improved the outlook for patients with both the AL and the TTR type. But it's important, and I like to look at these curves because it highlights the fact that, the mortality rate is really staggering, especially within the first year. And a lot of that is related to the fact that patients, don't get diagnosed in time, oftentimes have, symptoms for years that are attributed to, just run-of-the-mill CHF or diabetes and common treatments for those things are not improving those patients' symptoms, and a diagnosis of amyloid is not thought about until, really significant organ involvement. So as an internist, you'll likely be the patient's first point of contact. And if you suspect that a patient has amyloid, how should you proceed? So this is just one kind of algorithm. There's a few, that you can look up, but it gives you a roadmap of how you should kind of proceed with testing to be able to come up with the diagnosis. So if you have a clinical suspicion, then, at least that's the first big barrier that you've kind of crossed over, is to have the suspicion in the first place. The next step is to really take a detailed history and examine the patient, looking for some of those kind of signs of amyloid. And then a simple blood test you can do to check to see if there is a monoclonal gammopathy. So this could be a serum or urine protein electrophoresis immunofixation, and then a serum-free light chain assay. This would help identify if there is kind of an underlying monoclonal gammopathy again. If the blood test is positive, then you can go looking for a tissue biopsy. So this oftentimes requires a bone marrow biopsy and a fat pad biopsy. And if those are positive, again, for just amyloid, you have to go one step further and actually get the typing done to confirm that it's the light chain type. If for some reason the biopsy is negative, you can certainly go for direct biopsy of one of the organs that you suspect. Again, if it's a cardiac patient's coming with cardiac symptoms and you think it's cardiac amyloid, you can use the bone marrow and a fat pad as a surrogate site. But if those are negative and you still have a high suspicion, you can certainly biopsy the organ involved. If the blood test is negative for a monoclonal process or monoclonal gammopathy, and you still suspect that there's amyloid and perhaps more now towards the TTR type, you can start with something like a pyrophosphate scan to look for the TTR cardiac amyloidosis. If it's positive, then it's highly likely that that's cardiac TTR. If it's negative, but your clinical suspicion is still high, again, you want to go and look for a tissue biopsy and then type to confirm that this is exactly what you're dealing with. If you do find that there's TTR amyloid, then again, genetic testing to see if it's the wild type or the hereditary type is important, not just for potential treatment, but also for what it may mean for the family and other generations in screening. So there have been many improvements in how we treat both the AL and the TTR type amyloid. There's been several FDA-approved therapies over the last several years that's really impacted patients' quality of life and, again, prognosis. When it comes to the AL type, again, once you identify that it is the AL type, you also want to figure out if it's localized, meaning it's limited to just one organ, versus systemic, where it includes multiple organ systems, as treatment is directed based on if it's localized or systemic. Overall, supportive therapy is crucial for these patients. Again, they probably have multiple subspecialists that they're following up with, whether that's cardiologist, a nephrologist, a GI, physical therapy, speech, again, depending on which organs are involved. But for localized AL, the treatment really is supportive care, really kind of organ-directed therapy. If there are multiple organs involved and it is a systemic disorder, then typically treatment is a plasma cell-directed therapy. Really trying to eliminate the source of the light chains, which is the source of the amyloid proteins. And that's done either through combination chemotherapy or even something like an autologous stem cell transplant, really targeting the clonal plasma cells, which is the cause of the light chain abnormal productions. For the TTR type, there's multiple kind of areas where you can interrupt where the treatment is available. So there's the silencers, stabilizers, and the fibril disruptors. So in terms of the silencers, these would be medications that block the protein synthesis, so you don't even get the formation of the TTR proteins to begin with. There's also the stabilizers, which are treatments that can actually help stabilize the TTR protein in the tetramer normal conformation, preventing them from being dissociated into the monomers, which are the actual source for the TTR or the amyloid fibrils. And then fibril disruptors, which are really looking at trying to actually remove the deposited amyloid proteins from the organs. And there's certainly ongoing clinical trials looking at newer agents in all of these areas. So as internists, again, and even future subspecialists, whether that's cardiology, nephrology, GI, hem-onc, it's really important to keep a wide differential and to keep amyloid in mind when you're trying to figure out what's going on with your patient. Keep a high level of suspicion. And if amyloidosis is identified, make sure you get typing and really look if it's localized or systemic for it to help dictate treatment. It's important because early diagnosis, early detection, and early initiation of treatment really can impact the progression of the disease. It can impact organ function, organ demise, quality of life, and overall survival. And so, again, really trying to advocate for your patients, listen to your patients, and think broadly about what they're complaining about, like the broad differential. It's an exciting and hopeful time for our patients with amyloidosis, but it's our job to really to listen and to help navigate as they're going through this process.
I hope you found today's clinical overview by Dr. Sarah Lee informative. If you'd like to watch her PowerPoint video presentation, you can find it on Mackenzie's Mission YouTube channel under the Expert Insights playlist. Thank you for listening to the All Things Amyloid podcast. If you find our podcast informative, please follow and share it with others. If you want to learn more about the work we're doing at Mackenzie's Mission, please visit mm713.org. We'd also like to thank AstraZeneca Pharmaceuticals, Alexion Pharmaceuticals, Alnylam Pharmaceuticals, and Bridge Biopharma for their sponsorship to help raise awareness about amyloidosis. We hope you stay tuned for future episode drops. Thanks for listening.